Dear colleagues, good afternoon. I'm sorry that I cannot be with you at the Blade, but this is the COVID era, and we'll hope that the next time we'll be all together. In this short communication, I will show you some data we obtained in our study. We conducted this in last years. And as you can see here, the topic is the prevalence and distribution of central hypertension in general population, EHUH2 study. EHUH2 study, EHUH is acronym for Epidemiology of Hypertension and Salt Intake in Croatia. And 2 means this is the second one because the first one we finished almost 20 years ago. So the main aim of our research project was to analyze prevalence, awareness, treatment, and control of brachial hypertension and compare current status with data we obtained 2 decades ago. We also wanted to determine the salt intake in our population. In 24 urine samples, we are determining salt, potassium, and also iodine. But besides this, we will have data on the prevalence of overweight and obesity in our general population, on dyslipidemia, on prevalence, treatment, and control. And we will focus also particularly on familial hypercholesterolemia, on LP small a. We will analyze diabetes and prediabetes, hyperuricemia, and also not only the prevalence, but also the way how our patients with these metabolic disturbances are treated and whether the control is obtained. We will measure, and we are measuring pulse velocity and central blood pressure using a mobilograph device. We will be able to determine prevalence of atrial fibrillation, as well as the prevalence of HFpEF, because we are determining a lot of cardiac biomarkers. And finally, we will be able to have data for the first time for the Croatian population on the prevalence and stages of chronic kidney diseases. At the end, we will analyze the characteristics and prevalence of thyroid hormones, because we consider this important in context of our salt reduction programs. This is a random sample of adult Croatian population, and here is the way how we are enrolling our subjects. And you can see here the exclusion criteria. The exclusion criteria are those usually used in the similar studies like this. This is the current status, and you can see here until now we enrolled slightly more than 1,700 subjects. COVID slowed down the enrollment process, and there are some regions in Croatia which will be included in the next few months. We hope that Corona will enable us. You can see here differences in continental part and coast part, and also how many subjects are coming from urban and how many subjects are coming from rural areas. All in all, this will be a representative sample of Croatia general population. Before going to the main topic of this talk about central hypertension, I will show data on brachial hypertension we are usually treating. And you can see here, this is crude prevalence, not age adjusted. You can see here that the prevalence increased in last 20 years. So data from 2002 to 2005 compared to data we obtained in analysis in the last 2 to 3 years. The prevalence now is 6% higher, but awareness is better and much more hypertensive subjects are treated. And because of this, you can see here, excellent result. The control is much better in Croatia now than it was 20 years ago. This is probably due also to our achievement with salt reduction program, because salt consumption is significantly reduced in last 10 years in Croatia, but also the usage, much more frequent usage of fixed dose combination. The situation is similar between men and women. And now go to the central blood pressure. There are many controversies related with central blood pressure. We know all of them. And the first question is, why should we measure central blood pressure at all? Is central blood pressure superior to brachial blood pressure on predicting target organ damages, cardiovascular events, and mortality? And then, should isolated central hypertension be treated? Should central blood pressure be one of targets? What should be the goal if this is the case? Should we treat hypertensive patients with central hypertension more aggressive? And do antihypertensive drugs have different effects in central blood pressure despite similar reduction in brachial blood pressure? And maybe the most important questions, how should we measure blood pressure? And how precise and reliable are non-invasive cuff methods? And is central blood pressure truly what we measure with devices we have now in our hands? Our aim was not to answer all those questions. Our aim was just to analyze the concordance of brachial hypertension with central hypertension in our population and to determine characteristics of subjects with isolated central hypertension. Here, a brief presentation of methods we use, and what is most important, we use mobilograph device for measuring of central blood pressure. This is also important that urine and blood samples were analyzed in one laboratory, and brachial hypertension was defined as blood pressure above 140/90 and or antihypertensive therapy, and central hypertension was defined using age gender specific thresholds for mobilograph. Recently, Pavia and co-workers published data on large number of subjects where blood pressure was measured using mobilograph, and we use 19th percentile for both genders for each decade. And here are our data. You can see here the prevalence of concordant normal tension was 30%, the prevalence of concordant hypertension was 60%, and the prevalence of isolated central hypertension was 4%. When we use other criteria for central hypertension, when we use unique number 130/90 millimeters of mercury, which is proposed by several authors, then you can see here that the prevalence of isolated central hypertension is significantly lower. We wanted to use this criteria because many other authors use these criteria and not criteria specific for mobilograph. This is important because many others authors are using also type 2 device, what is also mobilograph, but from different companies. So in that way, we can compare our data with data from other studies. And what we found here, you can see here the prevalence of isolated central hypertension was the same in our group and the group of Chuang. And I would like just to underline that we both used type 2 device, mobilograph and microlife. And quite contrary, when we compared data with a study which used type 1 device, SphygmoCor, you can see here that the prevalence of isolated central hypertension was significantly lower. So we found here the significantly lower prevalence of isolated central hypertension is when we used universal criteria of 130/90, then when we use age gender specific criteria for mobilograph. So it is important which criteria we are using. And the second observation from here is that significantly higher prevalence of isolated central hypertension was obtained when using type 2 device, regardless it is microlife or mobilograph, compared to type 1 device, which is SphygmoCor. Why is it so? Because type 1 device significantly more underestimates the true central blood pressure than the type 2 devices. So you can see here the difference in underestimation, and because of this, the prevalence of isolated central hypertension was significantly lower in study which used device type 1 compared to studies which used device type 2 like ours. So let's go back to our results. You can see here the prevalence of isolated central hypertension was 4.2. Isolated means that they have normal brachial blood pressure. So the question is, should we treat the patient with isolated central hypertension? The other interesting group is coming from the cohort of newly diagnosed untreated brachial hypertension. You can see here in this subgroup, majority have normal central hypertension, but there is 1/3 have also central hypertension. So the question here is, should we treat more aggressively patients with brachial hypertension associated with central hypertension? And if yes, what should be the goal, the brachial blood pressure or central blood pressure? Here are characteristics of our untreated subjects, and here is the brief summary. They are older, they are much more diabetics with isolated central hypertension, visceral obesity, and of course, they have higher brachial blood pressure. And here are metabolic parameters, and you can see here that subjects with high central blood pressure have higher fasting blood glucose, high uric acid, total cholesterol, particularly LDL cholesterol, and triglycerides. They have higher salt intake, and they had higher albuminuria as well as pulse velocity. At the moment, we didn't analyze ECG parameters, but it will be done very soon. So in addition, they have higher prevalence of metabolic disturbances, LDL above goal, higher salt intake, and more target organ damages, more albuminuria, and stiffer large arteries. So in addition, or maybe independent to high central blood pressure, they have high or very high cardiovascular risk. So they deserve more aggressive therapy regardless maybe of central blood pressure. And surely we have advised them to reduce salt consumption. Now go to treated hypertensive patients. Here you can see in the group of controlled hypertensive patients, those whose brachial blood pressure was below 140/90, 12% had uncontrolled central blood pressure. In the group of hypertensive patients who did not achieve blood pressure control, whose brachial blood pressure was above 140/90, you can see here 37% had higher also or uncontrolled central blood pressure. So the question is, should we consider central blood pressure when tailoring therapy? Should we here continue or introduce antihypertensive drugs, or should we here treat more aggressively? And again, here characteristics of treated subjects. Again, brief summary. Again, similar, like the untreated subjects, they are older, they're much more diabetics, they're much more visceral obesity, they had higher brachial blood pressure, but also higher heart rate. They also had higher presence of metabolic disturbances, particularly higher uric acid and higher triglycerides. And you can see here that treated hypertensive subjects with uncontrolled central blood pressure had significantly higher albuminuria and higher pulse velocity. So they had more target organ damages. So like untreated subjects, the question is whether they should be treated regardless of central blood pressure more aggressively, or does central blood pressure additionally contributes to this high cardiovascular risk. So here are my conclusions. There is no difference in the prevalence of brachial and central hypertension in our cohort. Prevalence of isolated central hypertension in our cohort is in line with reports from the literature, but I have to remind you only in those studies which use devices similar to ours. Untreated subjects with isolated central hypertension have higher global cardiovascular risk and more target organ damages. Treated subjects with uncontrolled central hypertension have higher global cardiovascular risk and more target organ damages. So the question is, as I already said, regardless of central blood pressure, they deserve more aggressive treatment. And I will come back again to the first slides of my talk. The question is, why should we then measure central blood pressure at all? Should we measure or not? And does central blood pressure independently contribute to TOD? Some studies say yes, the others said no. And should therapy be tailored according to the central blood pressure? You can see here I put 3 question marks. So data from studies with type 1 and type 2 devices should be analyzed separately. You have to remember this. And what we needed, more precise and more reliable methods of central blood pressure measurements before central blood pressure should be introduced in a general clinical work. Thank you very much for your attention.